Now we're going to turn to Gita for this discussion of her work at Possible Health on advancing primary care.
Good morning and good afternoon, good evening to everyone. I wanted to start with also a note of gratitude for our colleagues who are working with patients affected by COVID-19 and everything that they do every day. And also to the organizers of this meeting that have pulled this off in a very short notice, including with people that, like me, who are not as tech savvy as some of you. My name is Gita Pillai, and I'm the CEO of Possible. We're an NGO, a nonprofit organization that supports integrated health services in remote parts of Nepal. I'm participating from Washington, D.C. area. Just a quick note about me. I've spent most of the past 20 plus years in leadership positions based in India, Central Asia, Cambodia, and other countries, working on large-scale programs in close partnership with the government, focused on achieving population-based coverage and health outcomes. This includes the Urban Health Initiative program that was supported by the Gates Foundation in India, and the Integrated Nutrition and Health Project, which was supported by also in India, as well as the STRAW Plus Quality Improvement in Health Systems Strengthening Project in the 5 countries of Central Asia. I only recently joined this incredible team Possible, or the Possible team, in 2020. So this is actually my first platform to share the work of Possible. Can we go to the next slide, please? So in line with the Nepali Constitution and global health frameworks that declare healthcare as a right for all, the Possible programs were initiated by a highly committed team of individuals who saw tremendous need and a void in services, as well as knowing that the technology and strategies to reach this remote population were within their hands. This started about 10 years ago, and there have been remarkable achievements over the past 10 years that demonstrated that value-based care delivered in remote, resource-poor settings is possible. So in this picture, we are looking at, well, Possible works, just to highlight that Possible works with government and NGO partners to expand available, affordable, quality care, and in this case, to areas that were not, where it was not available earlier. This is a photo of Bayapata Hospital in Acham district or province, which has some of the worst health and accessibility indicators in Nepal. Here, Possible provides integrated care that includes outreach to homes, a service at health posts, as well as at the hospital level. Just as a note, as we look at COVID-19 spread, we're also very acutely aware of what this might mean to communities such as the one where we operate in low resource settings, such as in Nepal, and to the facilities and providers in the context where we work. Given the very tangible progress in health infrastructure, facilities, and infection control practices and quality evidence-based standards that are in place that were not there before, there's a sense that there's an elevated readiness to respond to outbreaks such as the one we have today, but there's also deep worry about how it might, we will be able to cope and how it might impact especially resource poor countries and their health systems and their vulnerable populations. Next slide, please. Just to provide you with some context, for those of you that have visited remote provinces of Nepal, you can fully appreciate the context as well as the resilience of the Nepali people and the challenges to the delivery of quality healthcare at lower costs. In Acham, one of the provinces where we support programs, and in Dolica, those are the ones that are highlighted here. In Acham, the challenge really is remoteness and distance from many other health services and the ability to reach services. And in Dolica, they continue to work on efforts to rebuild after the earthquake. This is an earthquake affected area. Next slide, please. Our implementation strategies are an integrated health model that includes services at home and in communities, as well as at health posts and at hospitals. Today, where there were no or very limited access to health providers or trained health providers, there are over 100 health workers in each of the sites and health providers working across the continuum of care. These photos that in this slide highlight the community counseling components, as well as the services provided at health posts and the surgical services at the hospital level. Next slide, please. In addition, there are several innovations that we have incorporated that, including digital health innovations that allow us to expand access to information, referrals, and care in these sites where we work. I want to highlight here also that the providers that are working in these sites and areas are highly motivated, not only by the fact that they are able to function in facilities that support best practice, but the clear indication of progress towards health outcomes and health indicators that they're contributing to, and the continuous exchange with universities and with practitioners that come to visit the site or that they go to visit, that enable them a platform for continuous learning as well as training. Next slide, please. As I mentioned before, a key component to value-based healthcare is the focus on outcomes, and the outcomes as determined not only by the health system, but by the real tangible benefits as perceived by the people who benefit from the system. In these particular areas, we've seen a dramatic increase in institutional births, which is obviously connected to reductions in maternal mortality, as well as a reduction in under-2 mortality, improved chronic disease case management and control, and improved case detection and treatment successes. Next slide, please. Our work falls into 3 streams of or pillars of work, all focused on integrated healthcare delivery and all focused on population level impact and coverage. The first sort of pillar is demonstrating that integrated care from home to hospital in line with the Ministry of Health strategies can be done in remote areas of Nepal, and that innovations that can be incorporated to improve quality of care, the reach of care, as well as cost efficiencies. And this becomes a center for teaching and training and learning. The second sort of pillar is that integrated care can be replicated to support the government's approach to a municipal care model, and that in line with the gains we've noticed with a model that rewards and highlights learning, that the networks of continuous learning and growth can benefit the acceleration of system successes. And the third key pillar is the close link to research and the generation of evidence on best practices of integrated healthcare that can inform and shape policy as well as practice. This includes in chronic disease case management, as well as mental health, and the priority maternal and newborn care and child health strategies. Next slide, please. Here I just wanted to highlight the importance of measuring value, both from the client or people perspective, as well as from the system or program perspective. Though it is important for all to focus on the health outcomes, which the program may define in terms of coverage rates of health practice or mortality reductions in mortality rates, or institutional delivery rate, for example. The patient obviously defines it in terms of their wellness, their experience with health seeking and health treatment, and that they are alive and thriving as a result of their ability and agency to access health services. The second key element that is related to quality, and that the quality which we may define as adherence to evidence-based best practices, that the client also evaluates quality from their perspective of their satisfaction with how they were treated respectfully, and their ability to interact with the system in an effective way. And the last, of course, is a note on cost. And here what I want to highlight is that it is more costly to reach the last mile of these most marginalized populations, where we have an obligation to ensure quality health services and their right to access quality services, and that we may need to develop a different yardstick on how best we do the cost and value calculations in reaching these populations that are especially vulnerable. So thank you very much.
Gita, thanks for your excellent presentation, and congratulations for what Possible has done, and in your limited time there, what you've been able to add to those impacts. We really appreciate your joining us today and look forward to the further discussion.